Hi, I'm Jay Miller, and today we are focused on the healthcare field. We hope this will be an ongoing series where we have people from Signature Healthcare Brockton Hospital in our studio to talk about what's happening at the hospital as well as advances in the medical field. To my left, we have Dr. Deepti Seshadri, and to my right, we have Dr. Rolf Frater. Doctor, tell us a little bit about what you do at Signature Healthcare, your job title, and what goes in to what you do.
Well, thanks for having me. I'm Dr. Deepti Seshadri. I'm a colorectal surgeon at Signature Healthcare, Brockton Hospital. I am double board certified in general surgery and colon and rectal surgery. I am the only fellowship-trained colorectal surgeon at Brockton Hospital. I do elective surgeries and emergency surgeries at the hospital. I see patients in both the inpatient and outpatient settings in my office at 110 Liberty Street. I treat a wide variety of colon and rectal disorders, both cancerous and non-cancerous. I've been at Signature Healthcare for about 2.5 years now.
Excellent. And Dr. Frater, you are familiar with some people in Brockton. You arrived here not too long ago. Tell us what you do.
Well, thank you. It's a pleasure to be here. I was recruited and started a little over a year ago, March 2016, as the Chief of Medical Oncology. Before that, I had a similar role, Director of Medical Oncology, Chief of Clinical Research at the Dana-Farber South Shore Cancer Center, which I had the privilege to help start up with a number of other physicians. But here, we're trying to do the same thing here in affiliation with the Bethesda Medical Center. That is, come up with a comprehensive oncology program, and that includes medical oncology, surgical oncology, such as Dr. Seshadri, and others, radiation oncology. And the idea is in preparation for the Cancer Center to have the program up and running before we move in.
Excellent, excellent. And that leads to the big topic of conversation around the city. There's some construction going on campus. Could you tell us what's happening over there right now?
Yeah, this is very exciting. I think this is very important for the Brockton community and then surrounding communities for the population here. We are building and will soon open in less than 6 months a comprehensive cancer center. This is a 40,000 square foot, 2-story new construction, absolutely state-of-the-art, which will facilitate what we call personalized, comprehensive, multidisciplinary cancer care. Which is to say, if somebody comes in with a complicated cancer, a rectal cancer, I can't do it alone, Dr. Seshadri can't do it alone, but together with our radiation oncology colleagues, we effect multidisciplinary care, chemoradiation surgery, and can cure this. This building will facilitate that. The first floor will have the medical oncology and radiation oncology divisions there. It will have an independent lab, phlebotomy station, a large infusion suite where members of my team will be working, the infusion nurses, an independent cancer pharmacy, and a fully functional radiation oncology division. On the second floor, there will be space for our Bethesda colleagues, for other members of the team, as well as administrative space, and it will probably be a clinical trial center. So this will facilitate close and constant interactions for patient care, which is something that hasn't been here yet and will be a tremendous plus to the Brockton community.
How important is that, doctor, having that immediate care available?
I think it's extremely important. Patients who get a newly diagnosed cancer want to feel like they're being taken care of from all angles, and I think that's what we're offering here. Quick, fast access, and then comprehensive multidisciplinary care is standard nowadays, and so we hope to bring that to our hospital.
And you were both talking before we went on air about a specific case where somebody called and then an appointment was set the next day. Could you tell us about that?
Absolutely. So it was a patient of mine that came into my office. We scheduled her quickly for surgery to obtain a diagnosis. Within a few days, we had our results from our pathologist who do an excellent job. And I had her come back to my office the very next day, and we are able to get her to see Dr. Frater for follow-up from a medical oncology perspective within 1 business day.
And doctor, what is the plan for a grand opening? of the building? Is that sometime in the fall or?
That's going to be sometime in the fall. The initial move-in will be in September. The festivities will likely be in early October, so to coincide with Breast Cancer Awareness Month.
And if there are people out there right now and they've been diagnosed and they're looking for some local care, is there something that they could do to reach out to you now or in the immediate future to at least set something in place, set something in motion?
Absolutely. Our offices are set up to manage these patients quickly, effectively, and get them in to see the physician within a day. So anytime there's any concern, the office lines are open.
Okay.
Yeah, I want to add a little bit on that because you raised a critical point here. We already have a fully functional multidisciplinary cancer care. That was one of the roles I was tasked to bring here, and thankfully with outstanding colleagues here in surgery, radiation oncology, we have that now. So Dr. Seshadri's patient is actually a woman in her 50s with an anal cancer. That can be a life-threatening cancer. The way we treat that is usually these days not surgical anymore. After a colorectal surgeon makes the diagnosis, it's typically a medical oncologist and a radiation oncologist together do what's called chemoradiation. Radiation therapy to the anal mass to start shrinking it and the environs, and chemotherapy really to act as what we call a radiation sensitizer. Think of it as adding to the muscle the radiation therapy. So radiation therapy alone is good. You add the chemotherapy to it, you really wipe this out. And these days, unlike, say, 2 generations ago, 30, 40 years ago, when they used to do this horrendous operation to remove the anus and you end up with a bag, that's almost never done anymore. I can count on one hand the number of patients who have required that in 20 years of practice. So this really underscores, Dr. Seshadri contacted me today and we put that patient in tomorrow. What patients really want, in my experience, is getting into a comprehensive system, in this case, our comprehensive cancer system, immediately. Be aware the physicians, Dr. Seshadri, myself, the rest of our teams are thinking about them, have a plan and get them moving forward, and put together their multidisciplinary team, which is to say a breast cancer is not a breast cancer. These days we individualize care for colon cancers, breast cancers, pancreatic cancers. You have to look at the patient, how aggressive it is, where it is, the genetics of it, to put together the appropriate team for them.
And I think one of the great things about our institution is that we have a fully functional multidisciplinary tumor board. I'm the surgical member on the oncology committee. Dr. Frater runs the oncology tumor board. And so we are all able to go over the imaging studies, the diagnosis, the pathology, and all of our clinical impressions together as a group so that everyone's on the same page and that the patient gets the care that they need.
And this is, there are some very difficult, advanced, aggressive cancer cases here. Just to give you a brief example of a patient who is currently going through the system now, it's a 47-year-old male who noticed all of a sudden he was having difficulty with his bowel movements. They just weren't normal, and that's never a good thing. So after his wife prompted him, of course, he delayed, but the wife got him in there. Dr. Texera, one of our gastroenterologists, performed a colonoscopy, and this gentleman, unfortunately, doesn't have just one cancer, he has 2 cancers. He has a very large rectal cancer, and on the other side of the colon, what's called the cecum, where just above the appendix is another colon cancer. So how do you treat that? Because the treatments are somewhat different here. And to make matters worse, he also has disease in his liver. Now, that's not necessarily a death sentence anymore. With modern chemotherapy, with aggressive surgeons, with specialized surgeons, colleagues of ours at the Beth Israel Deaconess Medical Center, Harvard Medical School, who specialize in liver surgery, we can still talk about curative intent, aggressive, curative treatment for patients like this. But that's going to require a lot of discussion, a lot of multidisciplinary care in a very short period of time to get this patient through that. And so that's what we've developed here now, and that's also what Tumor Board is for and what interactions with our colleagues at the Beth Israel are for.
And for the viewers out here, and for me personally, the advancement in cancer care, the last few years, people hear the word cancer, and obviously, if they're diagnosed with it, it's very upsetting. But the technology in the last few years, the advances made, how much has it been? How much progress has been made in not only fighting this, but coming closer to that golden goose, that cure?
Well, I'm a member of the American College of Surgeons and also the American Society of Colon and Rectal Surgeons, and I think that by being a part of the national organizations, that we're able to bring high-level, comprehensive, latest and greatest advancements right here to Brockton. And so I think that in terms of technology from a surgical standpoint, we're able to do most of our surgeries now minimally invasive, and they've been proven to have equal outcomes as old-fashioned open surgery. So I feel very confident that we're able to offer that here in the community. Also, I think that just like Dr. Frater was saying, some of these some of these diagnoses don't require major surgeries anymore that are very morbid and have some difficult complications afterwards. So in those cases, we're able to depend on our medical oncology and radiation oncology colleagues for newer treatments.
And just to add on that, I agree, and I think the progress has just been staggering. When I was a medical oncology fellow, which is, say, just after residency, finishing, learning how to become a medical oncologist, I had the privilege of training at the Dana-Farber in Boston, and that was when George Bush I was president, so not that long ago. But when I think about what we were doing back then, which was cutting-edge stuff, it's stone knives and bearskins. I mean, metastatic colorectal cancer, at the time we had 2 drugs for. 5-FU leucovorin, and you could increase overall survival by maybe 3 months, and everybody, frankly, was dead within about a year, except for those rare people who you could do a heroic surgery on. These days, 5-FU leucovorin still forms the backbone of what we do, but they're much more modern regimens. We use biologic agents, one called Avastin or bevacizumab, which is a designer antibody that gets in there and starts starving the tumor. It basically chokes off its blood supply. We have other targeted therapies and so on. So instead of 6 months, we now get people routinely to 3 and 4 years and beyond here. And there's more down the line with so-called immunotherapy, unleashing the immune system here. Just the pace is breathtaking, and the change and the improvements. We have a long way to go, which is why we're still doing clinical trials, but it's very significant advances.
And back to the building, what kind of input was taken as far as the design of the building and what would be offered? Was taken from the staff or the potential staffing and from the community as a whole?
Well, Mr. Holland, Kim Holland, our CEO, came here about 7 years ago and really started transforming things. Basically, took an interesting approach here. He took all the people who were needed here, physicians, administrators, social workers, nutrition, to just name a few, and basically he locked us all in a hotel for a weekend, for 2 days, and basically nobody was allowed to come out until we had designed the building here, and there were patients in there as well, and so all joking aside, we did what was called a chiclet exercise, trying to get the space in rough form for the 2 floors, 40,000 square feet, and then we got to a finer level of detail, and so it was planned, and there was a lot of discussion with all parties, including patients who have to experience this, what would work for them here, and I think that helped optimize the design, and that's ongoing as the building is taking form in terms of amenities inside, artwork, lighting. Patients, much more so than staff, are playing a very big role in that.
And we talked about quality of life. You hit on it a little bit, and I'd like to talk to you, Doctor. I'd like to ask you, as far as the quality of life, what's the responsibility of a doctor to help them manage their care? What lengths do you go to for each patient to make sure that they have the potential for success?
Well, I think that's a great question, and it's very important that patients be engaged in their own health care and their recovery. So right now, I'm actually in the process of spearheading an initiative called Enhanced Recovery After Surgery, or ERAS, which has kind of taken hold internationally and nationally at many hospitals, where we create a true multidisciplinary approach from the beginning. So that starts in, most of the times, my office, where the patient gets verbal education, written education, and then they go through pre-admission testing where the same information is given to them so that they hear about it multiple times and that they can start learning about what they have and how best to support their own recovery. And this will be carried throughout their stay. So I'm working with our anesthesia colleagues, nursing, physical therapy, case management, all to help decrease our complication rates and decrease length of stay in the hospital, and also improve patient experience, even though this is a very difficult time for most patients, and also help them take some control. And I think that's very important.
How long have you been in this field?
I've been in this field now for about 3 years. I finished my residency in 2013 and then went on to do a colorectal fellowship in 2014, and then I was brought here to Brockton.
Why colorectal?
That's a great question too. I get that question from my family and friends and also my patients that come into the office. And so I think what's interesting is that for a specialty, there's actually quite a wide variety of diseases that I treat. There's a wide variety of procedures that I do. I do major abdominal surgeries. I do small anorectal cases. I also do colonoscopies and remove polyps. And so I have a very varied practice, and I think because everybody pretty much has a colon or a rectum, I really don't have any limits as to who I see in the office. So there's always something new going on. It's a very academic field, so I do get that intellectual stimulation from it, and I think as our population ages, it's one of those things that spreading awareness on colon cancer screening and just raising awareness for our field is certainly rewarding for me.
You just brought up something interesting, Doctor. Our population is aging.
Yes.
And how does that affect the technology, the approach, from not only a person in a position like yours, but the overall vision and mission of a hospital like Signature Healthcare?
Well, I think if you look back over the last 80 to 100 years in medicine, until the early 20th century, you did better with a serious illness at home. More people died in the hospital. Your mortality was higher. And what did they die of? Infections. If it wasn't syphilis or something else, postpartum infections. As we got over that with antibiotics, the heart disease came to the fore. These days, the cardiologists have incredible technology to get people past heart attacks or fix them up before the heart attack. So cancer is now the great frontier here, and as the population gets older, as we've gotten past infections and heart disease, we have an aging population with a lot of cancers. And so public health initiatives to keep people active, moderate alcohol, no smoking, exercise, keep the mind going, will make for a healthier population and one better able to stand the treatments that we give. But I think as we get a better understanding of the molecular basis of cancer, we're also getting smarter in how we treat people. And I think more specific in how we treat people, and I think a good way to understand that is a disease called chronic myelogenous leukemia, CML. When I was a fellow in the late 1980s, it was a moderately common disease, several thousand cases a year, usually in people in their 50s and 60s, although you'd see it in younger people. About the only thing we could do at that time was literally blow these people up, wipe out the bone marrow, hope that the normal bone marrow came back before the leukemia did, and then maybe do a bone marrow transplant, if you could find a donor, which is not as easy as it is today with international registries. Then we learned over the last 25 years that there's a single gene called BCR-ABL that actually causes this leukemia, and through the work of Dr. Brian Drucker and others, we now have a drug called imatinib or Gleevec that inhibits this. And so we went from a disease that was almost universally fatal, that you literally had to drop an atom bomb on, to one now that most people survive 5 or 10 years beyond, they take 1 pill a day. So as we get smarter about this, more knowledgeable about the genetic underpinnings of cancer, we'll have more of these so-called targeted agents. As we understand what are called driver mutations, genes that are mutated that cause a cancer, and we inhibit them, we probably will have more effective and less toxic chemotherapy. But certainly as the population ages, you need to take what we call the performance status, how active a patient is, into account in what you recommend as treatment.
Anything to add to that, Doctor?
I would also add that screening is a big part of our cancer initiative. We want to make sure that our patients who are coming into our offices are getting the appropriate screening tests at the appropriate times in the appropriate intervals. So colon cancer screening, for example, generally we start screening around age 50. Some patients, depending on their ethnicity or risk factors, we will advise them to get screened earlier. If there's any changes in their overall health status, any bleeding, abdominal pain, changes in their bowel habits, then we kind of turn towards more of a diagnostic test. But it's really important for patients to be aware. I know we were talking about our aging population. There is some data saying now that colon cancers are happening in younger and younger patients. Not to scare people, but if things are, changing, it's definitely worthwhile to get checked out.
And that leads to my next question or topic is prevention. And what can people do? They're healthy. They've gotten regular checkups, nothing's wrong, but as far as preventative measures and extra screenings that they might be able to take, are there any out there?
Well, I think overall, like we've discussed, a healthy diet, low in red meat, smoking cessation, limiting alcohol intake are all very important factors. And then being aware, so knowing your family history, knowing when the appropriate time is to get screened and having those conversations with your primary care physician. And then being aware of symptoms to watch for.
Clinical trials.
Yes.
Will there be some happening over at the New Cancer Center? Or?
There will, and I just backing up a little bit, a very important part of this whole endeavor is our affiliation with the Beth Israel Deaconess Medical Center, one of the institutions of Harvard Medical School. We can do, Dr. Seshadri, myself, our teams, radiation oncology, we can comprehensively address probably 90 to 95% of the cancers we see here. But for those acute leukemias, for those ultra-specialized chemotherapies, radiation therapy, surgeries, it is invaluable to have a direct and immediate conduit into the colleagues at the Beth Israel Deaconess. And we share care. We send patients to them, they do their bit, they come back, and it's a two-way street here. And part of that is clinical trials. We made tremendous advances in CML, as I mentioned, a single pill pretty much cures that. For the vast majority of patients, but we have a long way to go in pancreatic cancer, in some leukemias, to name a few, in metastatic lung cancer. And the only way you're going to make advances is to address this scientifically with well-designed, carefully vetted clinical trials. And we have access to some, but as we open this, there will be a clinical trial center there, and we will be working with colleagues at the main campus center of Beth Israel Deaconess with these clinical trials. That's the only way to make real progress here.
And doctor, you also do some low-risk invasive surgery, other than just the cancer. Can you tell us a little bit about that?
Sure. So I treat cancerous and non-cancerous disorders of the colon and rectum. And so I treat colon, rectal, and anal cancer, and I also treat benign diseases like diverticulitis, Crohn's disease, ulcerative colitis, pelvic floor disorders like rectal prolapse, fecal incontinence, and then I do anorectal disorders as well, like hemorrhoids, fissures, abscesses, fistulas. It's by no means an exhaustive list, but also one of the reasons, again, why I went into this field in the first place is that there's a wide variety of things that a colorectal surgeon can actually manage.
And the passion comes through. You can tell as you talk about it, and that turns me to you, Dr. Frater. Mm-hmm. You've been doing this for a while. You're very passionate about this endeavor and how it's going to positively impact the community. When did you make your mind up? When did you say, you know what, I'm going to be a doctor and I'm going to be a darn good one?
Well, I think that goes way back. I was exposed to science and medicine from well before I could read. My father was very well-known, very accomplished microbiologist, research microbiologist at the University of Michigan. So I was exposed to that from the start. It was very exciting. And really, when at medical school at the University of Pennsylvania, I did what's called a dual degree program, MD, PhD. So had very rigorous research studies almost from the inception. And so was able to really combine the clinical and the research, which is one reason for going into medical oncology. It's exciting, it's ever-changing, and you can do exciting research and still take care of patients, both of which were important, whether it's basic science, which I did for many years, gene crunching, how genes might cause cancer, and now clinical trials. But this allows you to go, as I say, from the bench to the bedside, basically, from a discovery to trying to make it actually something useful.
And doctor, is there anything that we might not have touched on that you'd like the community to be aware of?
Well, I think what I would like people in Brockton to know is that most of the care that you need from a cancer standpoint can be done locally. It is very difficult to continually go into the city for care that may take weeks to months, and we can offer that here. And I think that's a very important thing to know because raising awareness about it is the first step. That's the reason why Dr. Frater and myself are here, is to provide high-level care that used to only be available at tertiary level centers like Beth Israel, Mass General. We would like to offer that here. And I think with our team, we're able to do that.
And you mentioned Brockton. We're talking about a larger area. We're talking about the greater Brockton area. And that impacts a lot of people. And
Absolutely, and I think one of the things that I've seen since being here is that we are seeing patients present with advanced diseases. And so we would like patients to be aware of symptoms and talk to their primary care providers, get hooked up with a primary care provider with Signature Healthcare so that you can be managed along the way.
And Doctor, to you, anything that you'd like to add or discuss?
Yes, I'd like to make one point to Dr. Seshadri's here. Cancer is a devastating disease. There's almost no individual or family who hasn't been touched by it in some way. It devastates an individual, it devastates the family, interpersonally, oftentimes financially. It devastates a community. To have to go into Boston for a lot of this care when you're feeling poorly is a major project, and that's why we have this here. And I want to add, and I want to give a shout out to my staff, my team, all the teams here. Our staffs bend over backwards for these patients to make sure they get in quickly, get through smoothly. We have navigators for that. And to try to make them feel as welcome and as much a part of family as possible. And that really can't be overestimated, the plus to that and how it helps the patient at a very difficult time in their lives. And that's something we will continue as we go into the Cancer Center.
Well, Dr. Seshadri and Dr. Frater, I want to thank you for coming in. And thank you for your patience on my, on my work, on my vowels and my syllables. We hope you enjoyed the show. We hope it was informative. And we hope to have, again, representatives from Signature Healthcare Hospital in Brockton coming back for ongoing discussions in the medical field. Have a good day. Have a good night. We'll see you around town, Brockton.